And hello, good afternoon, everyone. Thank you so much for attending the April edition and our final edition of our Public Health Speaker Series for this academic year. My name is Angela Hobson. I serve as the Associate Dean for Public Health, and I have the distinct pleasure of introducing our speaker for today. Dr. Matifazda Hlatshwayo Davis is the Director of the City of St. Louis Health Department, and she is joining us today to talk about leadership during COVID and also some successes and challenges in public health during this time and what's facing the city of St. Louis. Dr. Davis is received her medical degree from Cleveland Clinic Lerner College of Medicine and a master's in public health from Case Western Reserve University. She completed her internal medicine residency at University Hospital's Case Medical Center. She went on to complete her infectious diseases fellowship at Washington University School of Medicine and a one-year HIV fellowship and a two-year dedicated sexually transmitted infections fellowship. She's also done extensive work at the VA hospital and is really involved.
It's being recorded.
Oh, if I can just remind everyone to put yourselves on mute. Thank you. Dr. Davis is here today again to talk about leadership during these challenging times. I just want to first remind everyone to try to keep yourselves on mute. Second, we will do questions and answers at the end, but if you have a burning question that you want to go ahead and put in the chat, please feel free to do that while Dr. Davis is talking. And there will be plenty of time for people to come off mute and ask questions live at the end as well. So without further ado, I'm going to turn it over to Dr. Davis to share her slides and her talk with us.
Thank you so much, Angela, and thank you everyone for welcoming me here today. I think of this group as my people, my tribe, public health. So it's such a pleasure to be here today. I'm going to start sharing slides in a second. I'm really impressed by the turnout. You guys pack a large crowd. So thank you for being here. So let me work on screen sharing and we can get started. Everything look okay on your end?
We can see it in presenter or in not in presentation mode. Notes mode. There we go. Great.
Okay. So we're going to talk a little bit about well, a couple of things. We're going to talk about my professional journey. I think sometimes it's helpful for MPH students to kind of hear how people got to where they did. Mine is definitely non-traditional, and sometimes it's helpful to know that if you don't fit the mold, you're still going to be fine. And then, you know, COVID, obviously, I don't think I can get away without talking about the pandemic and public health response, but we'll also try to weave in a little bit around challenges that we've seen outside of COVID within public health as well in the future of public health. So we'll see if it's a little bit, it's a very, you know, I'm hoping to pack it all in and you guys can hold me accountable. So we're going to talk a little bit about COVID. Like I said, equity, if you know anything about me, you know, equity is the cornerstone of how I lead and how I approach implementation strategies. And so this will always be with the lens of how this impacts marginalized communities. Again, we'll talk about my journey, and then I'll walk you through a couple of our initiatives here at the health department and how we address those. So I think by way of starting, the reason why I am where I am today, and I didn't stay within clinical medicine, is because of health disparities and how they've impacted me specifically on a personal level and my intersectionality. I'm a woman, I'm Black, and I'm an immigrant. And so my intersectionality has me understand on a very personal levels what health disparities are, and from a public health perspective was always an area of passion. So when we talk about health disparities, I want to be very clear that we're talking about preventable differences in the burden of disease, injury, violence, or opportunities that then limit the ability to achieve optimal health for socially disadvantaged racial, ethnic, or other populations. Like I said, for me, this was very personal, but one of the first things that kind of drew me towards a career shift from infectious diseases clinical practice to public health was these devastating statistics we started seeing at the beginning of the pandemic that I'll walk you through in a minute. But what frustrated me and a lot of people who have done the work of disparities of health and social determinants of health is that this is not new. We've seen it time and time again, whether it be in HIV and sickle cell anemia, heart attack, stroke, colon cancer, obstetrical care, transplants. COVID-19 joins a long list for which these disparities are true. So you see an infographic in front of you, and it compares the impact of this very thing in different disease states, right? High blood pressure, diabetes, stroke, and all-cause mortality across all age groups, comparing African Americans to the whites to the white community. And you can see across the board, there's a disproportionate impact within the African American community. This became very personal for me. I found myself 7 months pregnant at the beginning of the pandemic in 2020, and the only pregnant woman in my department, the only Black woman in my department, feeling a lot of the pressures of the time from different lenses. And for ID, this is what we do, right? We live and wait and hope for epidemics and pandemics. When I was a first-year fellow, my phone was off the hook with from the emergency room. Anytime someone came off the plane from Africa, they wanted me to help them rule out Ebola. When I had my first baby, our first pregnancy, I didn't have even normal doctor's visits because my OB visits, the first 10 minutes would be taking consults from my OB about her pregnant patients in regards to Zika, right? And here again, I found myself pregnant at the beginning of this pandemic, and I joke with my husband that I may need to take a break from procreating because my babies seem to usher in either an epidemic or a pandemic at any given time. And so it was a very stressful time. You know, this is what infectious diseases specialists live for. We are thrust to the fore of kind of helping lead how we should respond to these epidemics and now this unprecedented pandemic. But I also was vulnerable myself, being a pregnant woman. There wasn't a lot of data around how COVID was impacting pregnant women. It was very low numbers, some studies coming out of China. And to add to that level of stress and uncertainty was Black Maternal Health Week came around, and I was bombarded with statistics about how I was 3 times more likely to die just by virtue of being Black. And that was petrifying. And I remember then having to have a very awkward, uncomfortable conversation with my OB doc, because I was already being told I may not be able to have my husband in the delivery room because of COVID precautions, let alone now just the fear that I, just by virtue of being Black, may not make it off the table. And so that plus this very unique time where very soon thereafter, we started to see these significantly disproportionate statistics around what was happening within the African American community and other minoritized communities in regards to COVID. Cases, hospitalizations, and deaths being significantly higher was really the call for me. It was really the beginning of a signal that I wanted to see myself engaged in leadership and advocacy, and really my life's work around this very issue. And so I showed you before you a table. If you look at the bottom half of the screen, this is a table that the CDC has kept current since the beginning of the pandemic that compares the rate ratios of minoritized, the 4 main minoritized communities within the United States compared to their white counterparts in regards to cases, hospitalizations, and deaths. And I don't need to lead you through each one independently for it to be clear that across the board, minoritized groups are more likely to get COVID, to be hospitalized, and to die than their white counterparts. And this has been consistent throughout the pandemic. I will say these numbers have improved since the beginning of the pandemic, which is hopeful, but they are still absolutely unacceptable when you think about the portion of the pie that the minoritized groups, as evidenced in the pie chart above, comprise in the United States. So that for many of us was the issue, was the concern. And for people who dedicated their lives to this type of research, the knowledge that this was not a first time and we'd seen this before, and a distinct fear that we were going to see a lot more deaths in our community and a lot more illness. And again, our communities being left behind. And so what that did was change everything for me. Prior to the pandemic, I was mostly a clinical infectious diseases physician. I did a lot of community engagement on my own time, but there weren't pathways that looked like who I was and what I wanted to be. There weren't clear pathways for promotion and advancement for people like me who do community engaged work. I was doing a lot of these things, what I believed in my own time, found it difficult to really find mentorship and sponsorship around what this could look like and how I could build this out in a healthy way. And so when it came time for me to sign a contract, like a lot of people do who have imposter syndrome, who may not see their interest and their passions reflected in sort of the traditional pathways for success in academics, I went the clinical route and tried to squeeze in a lot of my passions in and around those things. But here I found myself at the intersectionality of an unprecedented pandemic, these health disparities in marginalized and minoritized communities. And then, if you all remember, this was also an unprecedented time around racial injustice and police brutality, specifically in the Black community. And I remember being 2 weeks out of giving birth to our baby girl, and George Floyd had been murdered around the time. And I was a new mom, literally breastfeeding 2 hours, every 2 hours around the clock. We didn't have any help because we were, in lockdown, and we had a little 3-year-old in the house as well to take care of, as well as a newborn baby. So just the bandwidth to even engage. And as a Black woman, that acute and chronic trauma that we often suffer in our community silently without any sort of support in the places that we work. We're expected to show up and be just as productive, just as strong. A lot of times we're going through these things and you may be going through a tough time and people asking you what's wrong with you, bad attitude being noted, and what's different about a person. When these sort of, like I said, it's trauma, and it's not just acute trauma, it's acute upon chronic trauma, all came together. And that was the signal piece for me that I wanted to be a part of the change. And so really started to build a profile around being a public health leader within COVID on a local level, which then grew onto a national and international level. And that was done through the fact that I told you I had started doing these community engaged efforts within the community, started in anywhere anyone would listen to me as far as education. I was in barbershops, daycares, and you start to build relationships. People could start to come to you as a trusted messenger and leader around these topics in public health and infectious disease, as far as I'm concerned. And that grew. I was then nominated to be on the board of health for the city of St. Louis, one of only 2 people throughout Washington University who held that distinction. And then I was the co-chair for the biggest HIV collaborative within the region as well. But I also used this opportunity to become a visible, trusted messenger. Used to be very, very, very guarded about taking local media requests because of my imposter syndrome, started leaning into that, and that grew into then becoming a medical contributor for CNN, BBC, Al Jazeera, and other large networks, and really building a profile around discussing specifically lack of vaccine confidence and in minoritized communities. And so that was the pathway to then being tapped to be the next director for the city of St. Louis. And again, a non-traditional path, but a path that came out of a very personal and professional space that intersected. And so now I want to shift a little bit and talk to you about what I walked into as a new director of health for the city of St. Louis. We were a year and a half into the pandemic at this time. This is an epidemic curve from the city that walks you through what we were seeing since the beginning of the pandemic. You can see that around the time that I came in, we were just at the end of one of our second waves. This was at the end of the Delta wave with Omicron. I was coming in at a time where we were about to announce the fact that children 5 to 11 could get vaccinated. And one of my first tasks was to come up with a pediatric rollout for the entire city. But we were well into the pandemic at this stage. And so what does a new director walk into? Well, I did not have the luxury of just focusing on COVID. At this point, we're a year and a half in, and as you all are probably well aware, it's not like the rest of health went away during the pandemic, but it was overlooked a lot, right? So I had to, in tandem, have COVID and non-COVID priorities. And what those were behavioral health, violence prevention, and chronic disease. Interestingly enough, I inherited a health department for which not one person was employed to address those very things. And why is that? And that is because I inherited a very broken and depleted health department, much like many health departments across the United States, right? Fatigue and burnout, the salaries that public health folks get is way lower than what they would otherwise get in private sectors. That's even worse if you're working for local governments, where the pay is always low, and that is has been a chronic issue within the city of St. Louis. And so while I thought I would have the luxury of being able to address a pediatric rollout, for example, and build into those areas, it became very clear that a lot of the response would need to be inward. So I want to now talk to you about where we are right now by way of update, because I think a lot of people are interested in the new normal and what's going on. And so very soon we will be shifting away from the percent positivity rate that we've all become accustomed to leaning into, right? This is the percent positivity that tells that has been set by the WHO as one of the ways that we know whether or not we're in a good space with the pandemic. We, at the peak of the Omicron wave, were in the 35%, which is unprecedented for the city. We're now down to below 10, and in recent times below 5% case positivity rate. Our cases in zip codes have dramatically dropped, but we have seen a doubling in cases in the last a few weeks, specifically around COVID. Can you hold on one second? I just want to check something. Bear with me. Okay. My apologies. Are you seeing the slides okay?
Yes.
Okay, great. And so one of the things that has been consistently an issue since the beginning of this pandemic has been the disproportionate impact, again, on Black communities. Here on the screen before you, we've been tracking what this has been doing from a race perspective since the beginning of the pandemic. And the Black community, the African-American community here is reflected in purple. And you can see that throughout the pandemic, they have shouldered the burden of COVID more so than any other group. Only in the last month have we seen Caucasians making up the majority of new cases for the first time. And that's been since February. And that's been an interesting trend that we can also talk about as I go through this slide set. And so we all know that vaccinations, the impetus of vaccinations were really a triumph of science. For someone in infectious diseases, I can tell you that there was no way that I could have even imagined that we would not only get to a vaccine as quickly as we did, but one that is as safe and effective as the ones that we now have on the market and have had for quite some time. Here in the city of St. Louis, we've done a great job, but not there yet. As far as vaccinating folks, we have vaccinated 62%, almost 63% of the population. Boosting though trails significantly on only a quarter of the population being boosted. And so I want to move to the sort of things that I had to look at when I was then as the director coming in. One of the first things we had to do was address, like I said, a pediatric rollout. And for I gave you this picture, right, of a very dilapidated health department, one that had burnout. And my staff, I held a staff meeting, and the first thing they said is, we just do not have the capacity to even address the pediatric rollout. We don't have the people. We're already doing the jobs of 3 to 5 people, and just are barely keeping up with vaccines for the adult population. So what we did was we had to build out a pediatric vaccine rollout that focused on partnerships. And again, lent into equity, understanding that the most marginalized and minoritized amongst us, had a lack of confidence in vaccines, had a lack of confidence in traditional government, public health, and medical institutions, and needed those trusted messengers with a known track record of having earned the trust of the communities, rather than trying to slap that on for the purpose of this pandemic. So we leaned into an unprecedented partnership with our FQHCs, our local hospitals, and clergy advisory boards. We brought together a work group of 10 different trusted messengers, small community organizations. Like I said, the clergy were brought in. We brought leaders from migrant and immigrant groups, and did partnership clinics with them and our schools, leaning into the fact that for this age group specifically, the 5 to 11 age group, there was a unique need to provide a safe environment with the people they trust. And we know those to be their schools, their pediatricians, if they're lucky enough to have access to a primary care provider, and then our FQHCs who have already earned their trust. We were able to then vaccinate a record number of people within this age group with that first wave, and that, I believe, prepared us for the Omicron wave so well. So we did a lot of education. This is an example of how we also leaned into this two-pronged approach, not just vaccinating people, but educating people. And so a lot of people would say, listen, I'm from a predominantly white organization or background, but I want to be a part of the solution. What can I do to educate? So we would put together slide sets like this, where I would walk people through the 3 main ways to increase vaccine confidence. Ask simple questions up front without these sort of power differentials standing over people. If you're a physician wearing a white coat, making sure it's a private environment, using simple, accessible language, acknowledging and apologizing if your institution is part of the issue of systemic and institutionalized racism that creates valid mistrust within these communities. It takes nothing to say you're absolutely right, and I'm so sorry that that's happened to you or your family in these very institutions. And then to really listen to what their questions is, as opposed to anticipating, right, and educate them in simple and accessible language. We spoke to healthcare providers about the role they had played in these issues, around labeling folks as non-compliant, copying and pasting notes that are years old in some cases, and still labeling people as having drug abuse histories. Not understanding that people leaving against medical advice a lot of times has to do with the racial disparities and the social determinants of health I spoke about earlier. Labeling them as difficult, doing a sign out and calling someone crazy, and so impressing upon the person coming in that this person is a problem. And not understanding the real causes for pain in a lot of health conditions, and labeling people as pain-seeking. And so for me, I had to really think about, as a director of health, what did I need to focus on, giving that example of the pediatric rollout in the beginning, towards change and towards addressing both my COVID and non-COVID priorities. So again, like I said, it was that trusted messenger piece. I now meet regularly with different factions of leadership within the city, weekly with our school leaders, bi-weekly with our clergy advisory board, have established relationships with the 3 main migrant and immigrant health community leadership organizations. Again, make myself accessible to our faith leaders. I've done webinars, seminars, I'm there in person at events to sort of bridge that divide. And so really lifting those up. And I'm very unapologetic about going to first our FQHCs, federally qualified health centers, and community groups whenever there's an opportunity to partner with strategies, whether they be in a COVID vaccine clinic or in non-COVID related sexually transmitted infection work, where we do a lot of STI and HIV testing, we always go to them first because we know they are the trusted messengers who've earned those relationships. Developing trusted resources. When I first came into the health department, there was very little by the way of distinct policies that had been written down that had an equity lens that were available to the public. So one of the first things I did was reach out to the county and to Dr. Faisal Khan and request that we meet monthly with our boards of health to try to have a more unified regional response to a lot of what we do. So you may have noticed we just put out a joint policy on the new normal and what we expect for COVID going forward for both the county and the city. I tried to unify our quarantines, our test to stay, test to response treatments, because when I came in, there were just divergent policies in the city and the county that made it really difficult for folks to, at organizational levels, to know what to do. Schools are a prime example where there would be a 14-day quarantine in the city, a 10-day quarantine when I first came in the county, and they'd have to deal with children in different ways. So trying to establish a now foundational piece of trusted resources in partnership with the county that are founded on a bedrock of equity. And then really shoring up our data core. One of the things I was very fortunate to have is to walk into a very, very healthy epidemiologic core here in Bureau. We have doubled the size of it since I've been here in October. We have partnered with the Center for Implementation and Dissemination, as well as the Institute for Informatics, around doing data together in the future. And for me, that is important because Dr. Corey Bradley, a colleague and friend of mine, always says data is justice. And I believe that to my core, because data informs policy, and data is what we can use to advocate for funding for minoritized groups and in this as we move forwards towards equity. So I already kind of walked you through the pediatric rollout. We can talk about other key initiatives since I started. So the first is, you cannot move forward and plunge forward, just like I learned with that pediatric rollout I talked to you about, with anything before you heal what's happening internally. So for me, that meant really listening to my staff, talking, and we did a survey to talk about what were the big issues that they felt like had been going on here at the health department and how it impacted them. And staff morale was by and large the biggest thing, second only to salaries. It was show me my money and treat me like you care. And to me, that is completely reasonable. So have been an advocate, to the mayor's office around salary increases. If you heard the mayor's her State of the Union yesterday, where she did her first year address to the public, we have finally gotten there with the first round of salary increases across the board for city employees, a small but but significant step in the right direction. But it's been about being creative about how to show staff that they're valued. We now do employee spotlights, both internally and to the community, where we highlight the amazing work that staff are doing individually and as a group. I have maintained the ability to work from home for 2 days outside of the lockdown period in response to research that we know is abounding about how this impacted so many segments of our population, working moms, families, and people and mental health that have been impacted for our workers. So really trying to respond to that call. And then we also put ourselves in a position to be the first health department in the country that the CDC director visited. And so Dr. Walensky was here about 2 months ago, visited our health department, asked for an hour with me. I negotiated 6, and she was able to spend time with our staff. I was able to go to town asking for any and everything that I could on behalf of the city of St. Louis. But we also made it an opportunity for her to meet with the CEOs of our federally qualified health centers, for her to see equity in action and understand how policy at the national level really impacts folks on the ground who are doing this work. Because of that, we have now partnered with them on 4 different initiatives to help in the long term grow our workforce, and in the short term to start our behavioral health new bureau that I'll be announcing within the next month. And so that is such exciting developments to really look at how to address the health of your department first before you try to externalize your response as a leader. The next is, speaking to you about this pandemic response and the way that we have it's a very interesting time that I get to talk to you about it now because, we have a governor that's announced a pandemic over. We just heard this week that a federal judge ruled that masks won't be mandated in public travel. So we're having a challenge here in really stepping up and reminding folks who the trusted messengers are, who they are not, why public health is still so critical, and what this place that we're in the pandemic means compared to even 2 months ago, which is the reason for the joint policy and the reason that you see us, putting out a lot of press releases, doing a lot on our social media platforms to really educate the public. But what about the rest of public health that I talked to you about, being somewhat forgotten here? And that is where I've been focusing a lot of our time. I spoke to you about those 3 non-COVID priorities: violence prevention, behavioral health, and chronic disease, that aren't even represented in my health department. So now that I've had some time to really work on the internal workforce development, we are building a bureau for behavioral health and chronic disease. Violence prevention is not something that I believe that we can take on at the same time. So I've been working with the mayor's office, and she announced last night that the mayor's office will be opening an office for community violence interventions that's housed in the mayor's office that public health and public safety can feed into. All really positive initiatives in the right direction and a show of growth in both our COVID and non-COVID priorities. So I'll wind down by just saying that, the way that my life started is very different from who I am now. When I started, I was very much isolated, did not have a lot of confidence around who I knew I could be, did not feel like I had a lot of support in that direction. My life looked very much mostly clinical, trying to force the research piece because it was the only way that I knew to be accepted as a successful person in academia, trying to do the education piece on my own in the community, getting engaged in diversity and inclusion by way of advocacy, but also as another way to diversify my portfolio and to be successful, but really yearning to be in that community engaged space, but not seeing it as as an identified pathway for promotion and advancement in traditional spaces. Now, through that self-advocacy piece, through the belief of mentors and sponsors that I really went to and said, this is who I want to be, and this is the reason that really came out of COVID, if we're being honest, now have the pleasure of being where I know I should be, a director of health and associate editor for the Infectious Diseases Society of America's Health Equity section, and still very much trying to maintain my role as a medical and public health speaker and contributor around this space. And so I just really want to encourage all of you. I hope that my story encourages you to not give up on whatever your goal is. If it is in the traditional space, great, do it with passion, make sure you have mentorship and sponsorship. But if you, like me, continue to struggle with where you fit in and don't see a path that reflects you, do not give up and do seek people that see you for exactly who you are, because we need unique, quirky, sometimes different and weird like me that can end up leading a city of St. Louis. And hopefully this is just the beginning of where my pathway in public health and infectious diseases will take me moving forward. So I will stop now and open it up for questions and discussions. I hope this has been somewhat helpful, but would love to hear from you guys about what you'd like to hear more about.
Great, thank you so much, Dr. Davis. That was a really wonderful presentation and really taking us through your trajectory. And we are so thankful for your leadership in the city of St. Louis and the St. Louis region.
Thank you, Angela. Angela, can I just pause for a second to just acknowledge a giant and a mentor for me and many people who is on this call by way of Dr. Veta Thompson. I'm gonna try to do it without getting choked up. When I talk about the fact that, when I was going on this journey and didn't always feel seen and confident in who I was, it was Dr. Veta Thompson that was the first person that I saw and I said, I want to look like that. I want to be like that. I aspire to have even a portion of what this woman brings to the table. And she, like she has for so many of us lost souls in academia and outside of academia, made herself available to me, was one of the first people that reached out to me. I was a hot mess at the time. I don't even know why she didn't give up on me from the beginning, but has advocated both while I was at WashU and beyond but beyond that is a prolific leader in our region. So I just wanted to just really say that and acknowledge, because we need to give people flowers while they're still here. But when I talk about mentorship and sponsorship, it's people like Vetta Thompson that made folks like me believe that we could be who we are right now. So I wanted to thank you publicly, Dr. Vetta Thompson, and thank you for being here.
Great, thank you so much. And yes, I think there are so many people, a lot of us among this call, who are so very thankful for Dr. Thompson's leadership, and it is a really honor to have her here with us today too. So thank you, Vetta. I'm going to ask Jonesy or Smriti to do me a favor, and can you take us off spotlight? I'm going to ask everybody else that's here if you could do us all a favor, because we really want to have a conversation here, and I think it would be great for Dr. Davis to see your faces. So if you are willing to come off, I know there's some that are on taking yourself off of, or have turned your videos on, but if you could turn your videos on and we could have a conversation here, I think that would be great for our guests. So I see we have a few things in the chat here. Let's see. I think we have a question here from Alex. Thank you so much for your talk. I was wondering if you could talk more about the challenges St. Louis has been facing in getting more residents boosted.
Thank you for asking that question, Alex. It's been such a challenge, and I think the boosting conversation is multifaceted. I think we ran into, number one, pandemic fatigue, right? And for a lot of people, that feeling that, okay, I'll let you give me this vaccine this one time, but not a really good job of making people understand what this could look like moving forward, being transparent and clear in our education and communication from the beginning about how this may be a one-time shot, but this could look much like the flu vaccine where we need it multiple times. And I do believe that a lot of it we're seeing is being reflected in the pediatric community, where parents and caregivers have a much lower vaccine confidence in general around their children and want to wait. And so in the adolescent community where that's available, we've seen really low turnout there. And so I do think that that's been the challenge here. And it gets confusing again when the overall message is the pandemic is over, and us trying to really run behind those irresponsible types of messaging and reminding folks that you can't declare a pandemic over. And certainly, even if it were, you'd want to look to people who actually do this work to understand what that even looks like, right? So I believe that's been some of the challenges. More of the challenges are again around workforce. Depleted workforce make it difficult for us to have the same sort of waves. Here at the health department, I'll tell you, we were so depleted in staff here that we depended very heavily on our volunteer pool. The AmeriCorps and other groups doing a phenomenal job of helping us sort of fill those needs. And those folks have dwindled. We've cut to less than a third of what we used to have by way of available folks. So I think it's multifaceted, but those are some of the challenges that I think we've had there as well.
Oh, thank you. And I see
Alex, I'm happy for you to come off mute if that answers your question, if you had anything additional to ask along those lines.
That was great. Thank you.
Thanks, Alex.
And I see we have another question in the chat, but I'm going to ask a follow-up question about that since we're on the topic of workforce. And, pre-pandemic, I think, local and state public health, agencies were starting to face what we're thinking about a workforce shortage, with a lot of people in the public health workforce being of retirement age. And then now, on top of that, we have just the exhaustion from being involved in public health work in the pandemic, and what you've talked about with just low morale and low pay. And I really appreciate how you talked about some of the things that you're doing internally at the city health department to address some of those things. But I'm just wondering if you could give our students some advice or some encouragement on why they might want to think about local and state public health agency work as they pursue their master's degree and are thinking about jobs post-master's degree.
Man, such a great question. Thank you for asking it. It's a hard question, right? Because I don't want to lie to people and say, this will be an easy job, this will be a lucrative job. It's not, right? I took a pay cut, a significant one to do this job. And even in ID, compared to some of the other subspecialties, it's not as if we're the ballers, right, in clinical medicine. But I think it's about first of all, really being clear about who you are and who you want to be in the professional space. This is the most exciting time to be in public health, but it is also the hardest and most challenging time. Public health is severely underfunded. Folks in public health need to be valued a lot more. Salaries need to be addressed. And it's really hard for me to make a plea for folks to come into public health, knowing what I know about what those challenges are, right? So my advice would be to get creative about what that looks like. I think there are ways to be involved in public health without completely throwing away your ability to thrive and survive personally. I think a lot of people are doing great things with us in partnership. So we get to work with academic institutions who get to partner with us and get that local public health experience whilst they continue to maybe have another pathway. But I mean, I would still say, think about it and do it. I have never been this engaged, knowing that I've made impact on a day-to-day basis in any job than the job that I've done now. What I've been able to do since October is mind-boggling when I think about it. I still feel like I'm not doing enough. I still feel like I'm drowning under a wave of just 2 steps ahead, and then someone shoves me 50 back, right? But the work is so important and it's so needed. One of the things that I do in my role is I make sure that I'm doing some sort of forward-facing community engaged activity at least once a week if I can. And it's in those moments that I'm reminded of the impact of what we do, right? When we responded by buying hundreds of thousands of antigen tests and N95 masks to give out to minoritized communities because the federal program really made it necessary for people to have access to a working phone, internet, and able to do that. Giving people those boxes in person, letting them tell me what impact that had for them, their children, their families, their ability to actually be safe and thrive, it makes a difference. And so number one, I would say it is worth it. But number two, you can work with mentors and sponsors now to be intentional about how you can do that and not necessarily be unable to pay your bills, right? I think people are doing really interesting fused public health roles, whether it's in academia and local public health, private, and making sure that it still has a link to what's happening to local and regional public health. I think folks are doing really creative things, as evidence that by even my own career path. And I think that even if it's a transitional towards your final goal, some time in this space will really help you understand exactly what public health looks like on the ground so that it can inform how you approach whatever it is you decide to do moving forward. So that would be some of the advice that I would give.
Great. Yeah, thank you so much. And that resonates with me. I got my career start in public health and local public health. And I always think about, just how great of a, work experience that was. And that's what I describe it as to students whenever I'm talking about it. It is such a boots on the ground public health role, and learning how that, public health in action in the local community is something that I think is invaluable for anyone working in public health. So thanks, I really appreciate your insights there. I'll move along to questions from students instead of my own. We've got something in the chat that says, thank you so much for being here, Dr. Maddie. I'm wondering what kinds of priorities are emerging for the new behavioral health team and what kinds of behavioral health trends you've seen during the pandemic in particular.
That's a great question. So that new bureau is just is preliminary, but almost finalized. We have to make budget requests at the beginning of the year. They go through our budget division. They have to be finalized through our E&A committee here in the city. So that's happening this week. But provisionally, I've been told we will have at least budget enough to start. So it means building it from the ground up, right? Putting up job postings, actually interviewing and hiring people. So I say that to make sure that people are aware that this will be at least a 6-month turnaround. What's exciting is that I partnered with the CDC. So one of the things that came out of that visit with Dr. Walensky was a partnership with the national CDC team to help build workforce development, to provide us with some expertise around behavioral health. And specifically their interest is in the impact of the opioid crisis and substance abuse in general. So that will be one of the main things that we start off with. But I also would like to address initially, right, being thoughtful about, I'm not going to have 100 people team. I'm not going to have a clinical service to begin with. So what would be a great way for the city to position itself within behavioral health? And for me, I think a linkage to care model that sort of works off the same example of what we've been able to accomplish really successfully in the care of people living with HIV, and been able to really get people linked to care. You know, before linkage to care was formalized, you could see people, you know, arrive at an emergency room, test positive somewhere in the community, and take months before they were actually seen by a health provider of any kind. And we know that that delay in getting them care, the delay in getting them on antiretroviral therapy was detrimental. And so to provide a linkage to care in similar ways, and as a person who practiced as recently as September of last year, I can tell you that anyone who needs mental health consultation within the city and the region is looking at easily an 8 months to 1 year waiting time, right? And this is worse for folks in minoritized and vulnerable communities who don't have easy access to healthcare in general. So we would love to build out a linkage to care model for behavioral health and for mental health services throughout the city. We'd like to make sure that they're well represented with folks who deal within equity and diversity. And so working with our mental health board, Serena Mohammed, who has been a champion for this within the city, has been working with me over the last, since I came in October to start thinking about what they look like. They do a great job of keeping a directory, but those are the two main areas we'd like to speak from. One, out of necessity, right? If the CDC is going to give you free services and they say, this is our priority, I'm like, we can do that. And we know at the beginning of the year, we lost 21 lives to the opioid crisis within 1 week just in the city. And so we have a crisis here and an opportunity to address it. We have a great epi core that can help us sort of build out data around what's happening and inform interventions. And then we can partner with our partner agencies in the city to really address a response, right? But the linkage to care piece is what I'm really excited about. The next part of your question is what kind of trends have we seen in the pandemic? We know that mental health has always been an issue within our community, but it was exacerbated significantly within the pandemic and made worse by the fact that the people couldn't access services. And then you layer that by the fact that in Black and Brown communities within the city, there are healthcare deserts and that are even larger when it comes to mental health. That is a crisis, and it has been a crisis. And I fear that coming out of the worst part of this pandemic, we're going to see this at a worse level than it's ever been. So it's for that reason, it was important if I was given any level of budgetary support to expand the health department, that it be in the sphere of behavioral health. It will require that I lean into the expertise of known leaders within the community. So I've reached out already to WashU, to SLU, to leadership groups. There's a leadership collaborative called Center that represents a lot of the folks who do work within behavioral health that we're working with. So really just trying to lean into that expertise and build this out.
Great, thank you so much.
Thank you so much.
Ellie. And the next question is, you're mentioning the new normal. Camille says it feels like that's a term that's meant many different things to many different people at many different times. And can you talk a bit more about what living with COVID-19 might look like as we move more toward an endemic situation? For example, I feel in some ways we've taken a step backwards regarding masking guidance and confusing messaging.
Oh, Camille, how polite you are. I hate the term new normal. It's so annoying. What does it even mean? It's just one of those overused terms, but I have to use it when I'm speaking to folks because I know it's a unifying, like, common term that we can understand, but it's just so confusing, right? And then you so politely said a few steps backwards, like a lot of steps, right? Let's be very clear. It has been like a nightmare, what has happened because of some of the things I talked about. But the thing is, the job of public health doesn't stop, right? I get reporters. A reporter called me yesterday. She was sweet as pie. And she was just like, well, why did you feel the need to release this joint policy? And don't you think it's futile given the fact that people aren't masking anyway? And I was like, correct. Still got to do my job. Still got to do my job, right? And so that's the answer. The answer is still very much in a pandemic. Folks are confused, pissed off. I'm usually pissing off one half of the society. And if I do things one way, if not the other half, right? But I still got a job to do. Still my job. And so it's number one, making people understand that we're very much still within a pandemic. but understanding where in that pandemic we are. Number two, making people understand that you don't just declare them over, that moving from a pandemic to an endemic state requires looking at certain metrics, which is what you're seeing happen, this tension between, the data and what were the outputs for data, as evidenced by the change made by the CDC and even local health departments, shifting more towards looking at local hospitals, conversations beginning to come about comparisons between what we do, for example, with flu reporting. We're not there yet. COVID is not the flu right now. That's another thing I saw on the news the other day. Well, wasn't it Delta that was like, well, basically COVID is the flu? And I was like, I can't say what I wanted to say because this is a recorded public place, but just know, look into my eyes and know that bad things were happening in my head when I read that statement. So again, it's about positioning ourselves as the public health leader, helping people to understand where we are in the pandemic right now and how to look at it. So if you have time and haven't had a chance to look at it, that joint policy that we worked with so closely with the county is really a beautiful thing for anyone who's invested in public health and in this arena to look at, because we really lay out what it means to be within a COVID-19 pandemic right now at an individual level. What should you be looking at and considering, and where can you go for resources? And we do that too at sort of a community level and then the much larger national level, so that you can understand that it may not look the same. The decisions you make may not look the same when you're making individual considerations than when you're making them at a community level. And the last thing is to remind people that my job is the job of public health. So I'm not really here for the conversations around, well, my rights and my feelings and me. My job is community level and population level prevention, and it will always be with a lens of equity. And so I think that's the important part. It's also to do a better job about being honest with people, saying I don't know when I don't know, saying that this is an ever evolving field and that we may be in a different place in a month or 2 months from now than we are now, right? But being clear about why my recommendations around still strongly encouraging masking indoors stand. We were very quick to release a statement yesterday about where we stand with public transit and air travel, and why our message is different from the recommendations, right? Citing the increasing numbers in the local and regional and even national space, citing the 2 new variants that are now in play, and one of which makes up the predominant number of cases in the US, and citing the fact that we still have a significant people who are high risk, for whom we want to be able to protect and make sure that they are not hospitalized or succumb to death. So that's how that conversation around the new normal will be. And my hope is that collaboration with the county will make it easier for folks to be clear about where we stand in public health in this regard.
Great, thank you. And Allie, I see your question in the chat. I'm going to save that one towards the end, the last question. I'm going to skip that one just for now. I'm going to ask our colleague Susan's question. And she first says, thank you, Dr. Mati. We are lucky to have you as our director of the St. Louis Department of Health and as a wonderful model for others in the field or wanting to enter the field. I echo that sentiment as well. And could you please say something more about the challenges of improving sexual health in St. Louis, especially for adolescents?
So good to see you on here, Dr. Surratt. Thank you for your leadership and your advocacy around this topic. This is such a difficult play. If there's one place where politics has intersected in the way that we've seen in COVID, but maybe at an even more significant level historically, has been the area of sexual health. And there are challenges here because there's even legislation in place that really limits our ability to address sexual health education in the way that would honor what I think we would all like to see in the sphere of public health. And so I have been having a listening tour of sorts with folks in the community, have met with advocates across the board, starting with our school leaders around where they are and where they stand and what they'd like to see. They're very much interested in moving this conversation forward, but feel almost like they're working with their hands tied behind the back because of the legislative piece. Have met with Planned Parenthood leadership who have been phenomenal and want to give every available resource here as well. But have also started leaning into what's happening in community groups. And I think one of the things that's difficult is that when you talk to the most vulnerable, and when we bring this topic, because I remember, I was at a roundtable just 3 days ago, we brought this topic up, and a person said to me, a member of Dutchtown said to me, you know, Dr. Monti, I wish I had the ability to even care about sexual health right now, but I still have to, you know, I'm still trying to focus on 1, 2, 3, 4, and 5 in my life, right? That are priorities. And so it impressed upon me the fact that we need to put people in a position where they have the bandwidth to even understand how significant of a challenge that is. So what we'd like to see moving forward is to now start moving in an intentional way with the schools to see what they feel their needs are in regards to sexual health and education, and how they believe we can best help them meet those needs. We have started a conversation within our city councilor's office around the legislative piece so that we can understand where the health department can and cannot be positioned to move this forward in a helpful way. But for me, the commitment is always there. Sexual health is public health. It is a crisis, and we know that it is under attack right now at the highest levels in our country, and we're already seeing that play out in other states, and is causing significant morbidity and mortality as a result. And so it's somewhere that we want to move forward with post haste.
Thank you. And I know we just have a couple of minutes left, and I want to get to both the things that are in the chat here. One is kind of what you were just talking about, but the question from before is really how to manage other important public health issues. And his example is HIV during the time of COVID-19 in South Africa and Swaziland, and how people, people with HIV died and some became very depressed. So how did the St. Louis Department of Health manage pre-existing conditions in the context of the pandemic? And then lastly, I'm going to just add the last question in here, and you can kind of choose how you want to answer these. We have someone asking if there's a way for us to contact you in the future for more questions or to learn more about the St. Louis Department of Health.
Sure. So I'll start with the question about epidemics within a pandemic. I mean, the short answer is we didn't do a great job. Bandwidth wasn't there, resources weren't there. So, I'm sure we had more than low income and middle income countries did, but we just didn't do a good job. We have to own the fact that for a large portion of the pandemic, we focused on COVID to the detriment of other priorities. And that's just a fact. I will say that one of the areas of strength here at the health department is we've had a thriving HIV prevention section. And that's continued to do their work within the pandemic. We continued to do a lot of testing when our community engagement core had to sort of shut down because during lockdown, they weren't able to go out and do a lot of the community health initiatives that we do. We focused very much on education and still kept our offices open for for STI testing, linkage to care and treatment. We have strong relationships with our academic health centers as well, and Vivant Health and others in the community who also kept their work. We have really strong partnerships with our community groups, Williams and Associates and other groups, the SPOT and the ARC who do so much work within the care of people living with HIV. And then we have a Fast Track Cities initiative that works towards ending the HIV epidemic. So I say that was a relative area of strength, but even with all of those resources, we definitely failed all of our non-COVID priorities within COVID. That is a fact. We just released our annual report with the county. This was another joint collaboration just 2 days ago. If you missed the press, or for those of you who are interested specifically in STIs and HIV, the data came out from both the county and the city around where we are, and we still saw within the pandemic increases in certain areas around STIs and testing. And you have to imagine how bad that is when we know people weren't accessing traditional services during this time, right? And so this is an area of concern, and it's part of the new normal. How I said I hate that term, but is really understanding how we get back to the business of addressing our epidemics, our non-COVID priorities, at the same time still trying to deal with COVID. So I'm sorry, those were very rushed responses and surface level, but you guys asked questions that I could do whole lectures on in a short period of time. Very grateful. And then as far as how to contact me, I can put my email back on the screen for folks. Can you see it?
Yes.
Yeah.
All right, well, I know we are a minute or two over time, and we all know that you are probably extremely busy and are probably wanting to get to your next thing. So everybody, please help me in thanking Dr. Davis for being here today. That was a great talk. We really appreciate your leadership, and we really appreciate you taking the time to come here and share your insights and perspectives with us. So thank you so much. And thank you everyone for being here today.
Thanks, guys.
Bye.